Let me first welcome you to this lecture on coronary physiology, which I consider basic to understanding and handling one of the most important challenges in modern medicine. Many ask, why is it so important to study coronary physiology for somebody who is not a cardiologist? And the answer is because coronary or ischemic heart disease is the leading cause of mortality worldwide and across gender. There are important population and individual vulnerability because of the prevalence of risk factors which are relevant to coronary heart disease, such as unhealthy lifestyles, metabolic and hemodynamic dysregulation, such as diabetes and hypertension, genetic factors, environmental conditions such as pollution, noise, and stress, shared mechanisms with medical diseases such as cancer and even surgical conditions. It's important to understand why fatal events are often unushered and unpredictable, such that sudden death could be the first and only manifestation of a silent disease. And also we have to remember that there are non-atherosclerotic causes of myocardial ischemia that must be understood and appreciated. The main objective of this lecture is to understand the fundamental principles which govern coronary physiology, which are very relevant to understanding coronary disease. Coronary or ischemic heart disease is the leading cause of mortality worldwide and across gender. Ischemia, defined as a mismatch of metabolic demand and blood supply, is a fundamental link to clinical events and mortality. Atherosclerotic plaque is the most prevalent pathophysiologic surrogate of ischemia. Ischemia may be primary due to interruption or severely reduced blood flow. Alternatively, ischemia may be secondary to inadequate increase of blood flow, secondary to disturbed physiology or pathophysiologic reasons. This is a very important statement that will become clearer later. The mechanism and nature of ischemia determine the gravity of the outcome clinically, ranging from chest pain to sudden death. Elucidation of the pathogenesis of ischemia, therefore, in every case is an essential clinical requirement and exercise. Remember that fatal events are often unushered and may be totally unpredictable. The key learning points of this lecture, therefore, are to dissect and understand myocardial ischemia, which is the basic link to coronary events and death. To do that, we have to define myocardial ischemia as a mismatch between myocardial oxygen demand and coronary blood supply. We have to describe myocardial metabolism under normal and clinical conditions, identify the determinants of myocardial oxygen demand, explain the linear correspondence between myocardial oxygen demand and required coronary blood flow, discuss the humoral and neural factors that control vascular tone and perfusion in the coronary microcirculation, explain three fundamental concepts relevant to coronary blood flow: autoregulation, transmural heterogeneity of coronary flow, and coronary flow reserve. These are very, very important concepts in understanding coronary physiology and the consequential ischemic conditions which ensue in abnormal situations. We have to describe the determining factors which influence myocardial perfusion, that is coronary blood flow, which are coronary diastolic pressure, heart rate, vascular resistance, tissue resistance, left ventricular and diastolic pressure, which you studied, coronary percent stenosis, and hence the trans plaque or trans lesion, loss of distal pressure under certain conditions such as exercise or pharmacology such as adenosine. We need to explain ischemia, induced mechanical, biologic, and microcirculatory aspects, relate the mechanism of ischemia to clinical outcome, and hence understand why fatal events may be unushered and unpredictable. This is a very important slide summarizing issues in coronary heart disease. Coronary artery disease is an inflammatory pathologic process. It hinges on inflammation involving a lipid accumulation and reaction to this in the epicardial arteries. Atherosclerosis occurs only in the vessels on the surface of the heart, but not in the small vessels within the myocardium. This leads to plaque formation and variable degree of vessel narrowing. We label them either as obstructive or non-obstructive depending on the severity of the narrowing. The disease is chronic. It's progressive and can be progressive even in clinically silent stages. This is extremely important. The pathology can become biologically unstable at any time. This is a very important and critical statement. It can become unstable at any time, typically due to plaque rupture or erosion, with resulting fatal thrombotic consequences. The dynamic nature of the coronary artery disease can be expressed in a spectrum of clinical presentations, categorized either as acute coronary syndrome, ACS, or chronic coronary syndromes. The pathology can be slowed or modified by lifestyle measures, pharmacological therapies, and invasive interventions designed to achieve disease stabilization and/or regression. Prevention remains the most important intervention in handling the burden of coronary heart disease, especially at a population level. Ischemic heart disease is governed by three interacting determinants: anatomic obstruction by the plaque, the biology of the plaque and its behavior, and microvascular function. Each may exist alone or in combination, producing distinct ischemic phenotype. The foundational mechanism behind coronary artery disease is the formation of the plaque, which is a buildup on the wall of the coronary arteries, causing the inside, the lumen, of the artery to become narrow, thereby impeding flow. This impediment to flow is not only passive, but is also dynamic and is subject to the physical principles of fluid dynamics, so that the more the flow across this area of narrowing, the more the pressure will drop distal to this area of narrowing, and this is a very important concept that will be clarified as we proceed in this talk. The other very important feature or manifestation of the coronary plaque is its ability to transform biologically, resulting in plaque rupture, thrombus formation, and sudden occlusion of blood flow to the heart. This is the most serious, this is the most feared complication of coronary heart disease, and this is the process which underlies fatalities. Patients who die suddenly in bed, patients who have heart attack, patients who have acute chest pain on the streets and die and require resuscitation. This is the process usually in most cases which is underlying this acute manifestation of coronary heart disease. So when we talk about ischemic heart disease or coronary heart disease, we talk about MACE, which is major adverse coronary events. And this is usually either due to mechanical or biologic changes. And the clinical manifestations or the clinical spectrum of this syndrome goes from silent pathology, where patient is totally unaware, to stable coronary state, to acute coronary syndrome due to plaque rupture and thrombus formation, to fatal or non-fatal myocardial infarction or death, or patient requiring surgery or special intervention to open the artery. I want to emphasize and underscore a very important fact that patients don't have to follow any obligatory path. Patient can go from silent disease to sudden death. Patient can go from silent disease to stable coronary syndrome, or to acute coronary syndrome, or any manifestation at any stage in the course of the disease. So we don't expect patients to go from through an incremental path from silent to stable to acute to heart attacks. Patients can present with any of the features. As a matter of fact, 50% of patients who die because of coronary heart disease, sudden death is the first and only manifestation of their disease. And this is why this problem is so challenging in real life at the individual as well as at the public health level. Most importantly, ischemia, and we'll talk about ischemia a lot in this lecture. Ischemia is the consequence of coronary artery disease, which links the pathology to morbidity or mortality or to symptoms. So to understand coronary artery disease, we must understand ischemia. To comprehend ischemia, we have to go to the basic mechanisms which govern coronary physiology, which is defined by myocardial metabolism and energetics, the fine balance between myocardial oxygen demand and blood flow, and the principles of coronary blood flow and the peculiarities of the coronary circulation, which is unique to the heart. Ischemia is the imbalance between demand and flow. It's the imbalance between how much the heart requires nutrients and oxygen and flow, and how much is the coronary artery able to deliver. And this is really the crux of the matter in coronary artery disease, and this is the basic mechanisms which define the problem of coronary heart disease and all the ramifications of this pathology. Myocardial metabolism underpins the basic functions of the heart, characterized by the fact that the heart is constantly beating, has a very high energy demand, and must continually generate ATP at a high rate in order to sustain contraction, which is the basic function of the heart, relaxation, which is equally important to prepare for the next cycle. Please note that relaxation is not a passive phenomenon, but rather an active ATP requiring process, which is the result of disengagement of the actin-myosin interaction that had taken place in the preceding cycle. It also has to support the basal metabolic processes, and extremely importantly, it has to support ionic homeostasis and electrophysiologic properties. In the normal adult heart, almost all, near 95% of ATP production is derived from mitochondrial fatty acid oxidation in the Krebs cycle. Let me stress again and highlight the principles which govern normal heart physiology. The basic functions of myocardial cells are to maintain electrical stability, to contract in systole, and to relax in diastole. The processes are aerobic and they require oxygen and nutrients. Oxygen extraction in the coronary bed is near maximum, reaching 70 to 80% in the basic steady state. And therefore, in case of increased oxygen requirements, such as physical or mental exercise, oxygen delivery can be achieved only by increasing blood flow. This is the only mechanism available to increase the delivery of oxygen and nutrients. Hence, the importance of plaques or lesions which sit in the lumen of the epicardial coronary arteries by becoming a source of physical or mechanical hindrance to myocardial blood flow. And here is the importance of coronary atherosclerosis or coronary narrowing. Therefore, it becomes imperative to review and understand what are the determinants, what are the factors which control the heart demands for oxygen and nutrients. And these are, by any order, they are contractility, the briskness, how brisk the heart is contracting, the heart rate, how frequent the heart contracts every minute, and the systolic pressure generated by the myocardium. The fourth component or the fourth factor is relaxation. Relaxation is a very important phase of the cardiac cycle, and this is an active, not passive process and extremely sensitive to ischemia. When patients develop ischemia, the first manifestation is a rise in their diastolic LV pressure, and the patients feel short of breath. We call it in Arabic al-khannaq sadri. As a consequence of this discussion, you can now appreciate the dual importance of increasing heart rate. By increasing heart rate, you have shortened time for diastole and therefore less time for perfusion. There is increased demand, and this fact has important therapeutic implications, and beta blockers are commonly used in patients with coronary artery disease to decrease oxygen consumption and favor the equation of demand and supply. So coronary physiology is best described by establishing a fine balance between coronary blood flow provided by the epicardial vessels and functional and intact microvasculature. We'll talk about it in a second. And coronary myocardial oxygen demand, which is determined by heart rate, contractility, and blood pressure generated by the contracting myocardium. A basic feature of the coronary physiology is the linear correspondence between oxygen demand and oxygen blood flow, and myocardial blood flow. Myocardial ischemia is a break in this equilibrium, and it occurs when myocardial demand exceeds myocardial oxygen supply, either by a mismatch where you have more demand than flow can be provided, or more dangerously by a situation where there is severe primary reduction of blood flow, as happens in patients during heart attacks, and we'll have a session on that. Having reviewed the demand side of the equation of demand and supply and heart perfusion, let us now turn our attention to the very peculiar coronary circulation, which is composed of the epicardial vessels. These are vessels 2 to 4 millimeters in diameter. They arise from the aorta and run on the surface of the heart, and these are the sites of coronary atherosclerosis. From the epicardial vessels, blood flow goes through a very large and extensive network of microvessels, 100 to 300 micra in diameters. These are vessels which are compressed with every systolic contraction, but they relax in diastole, and they are the site of fine-tuning of flow and demand. This is what we call autoregulation, defined by very fine changes in the tone of the microvessels, and this will fine-tune the distribution of flow to meet demand. Going from the epicardial or outer surface of the muscle to the deep layers of the myocardium, there is a transmural heterogeneity of flow, and this will be discussed later. Again, it's extremely important to remember that the perfusion pressure in the aorta is modified by the presence of narrowing in the epicardial artery, as you see in the middle figure and the blue arrow. So there is always a drop in pressure across any narrowing, and this will lead to decreased perfusion pressure in patients with coronary artery disease and obstructive plaques. Again, the coronary anatomy is unique and different in that the ejected blood from the aorta returns to perfuse the myocardium through the epicardial and deep penetrating network of vessels, which are subject to intense compression during systole, and therefore the perfusion will take place only during diastolic relaxation. And hence the importance of diastolic time, diastolic perfusing pressure, and all conditions of relaxation of the heart muscle. There are several conditions in cardiology which affect the integrity of diastolic performance and therefore could impede a normal physiologic diastolic perfusion of the heart muscle. Let us now focus on the vessels, the so-called the macrovasculature. These are 100 to 150 micra vessels. They are usually in a state of vasoconstriction. They will vasodilate in order to match the requirements of the myocardium. This vasodilatation is possible and achieved by several mediators, include catecholamines, adenosine, tissue levels of CO2, oxygen, hydrogen, and potassium levels. Adjustments of vascular tone is responsible for the fine-tuning between demand and supply, and any disturbance of this ability to vasodilate will result in a mismatch ischemia, where the heart is unable to meet its requirements because of resistance existing within the mural arteries, within the myocardial vessels, even in the absence of epicardial vessel disease or atherosclerosis. So the concept of ischemia, despite normal coronary arteries, is becoming a very important and relevant chapter in cardiology in 2022. The so-called INOCA, ischemia and no obstructive coronary artery disease, and this will be discussed later. Autoregulation, which is a function of the microcirculation, is a key feature of coronary circulation, actually microcirculation, and it's described by the fact that coronary blood flow remains constant regardless of perfusion pressure for a wide range of physiologic pressure. However, and please note that at low range of pressure below 60, this relationship does not hold anymore, and this is quite applicable for patients during ischemia where the perfusion pressure is low, and therefore pressure becomes a very important determinant of perfusion in such circumstances. Coronary flow reserve, we call it CFR, is another feature of autoregulation and an expression of the performance of the microcirculation. CFR is expressed as the percent increase of flow under conditions of increased demand or stimulation. As a result of autoregulation, coronary blood flow, or CFR, can increase 4 times. Please note that the resting coronary blood flow is maintained within normal range despite significant narrowing of the coronary artery, secondary to the ability of the microcirculation to dilate and compensate. Please note that CFR is preserved until 70% narrowing of the vessel, beyond which the CFR starts to diminish. The physiology we have just described has enormous clinical implications and significance. Because coronary flow reserve is preserved despite and until the vessel is narrowed by 70%, patients will have no symptoms, and they will even escape testing, such as a stress test, despite the presence of silent pathology. However, they will remain susceptible to the biological complications that we spoke about in the very early slide. Hence, the disconnect between coronary obstruction and coronary events and consequences. And this is a paradigm of enormous significance and remains to be one of the most challenging aspects of coronary artery disease. Going back to the special nature of coronary perfusion, the coronary blood flow not only varies between systole and diastole, but it also varies significantly within the depth of the wall of the myocardium. The blood flow goes from epicardium to the inner aspects of the myocardium, and therefore the deeper vessels are more intensely compressed during systole, and hence they are entirely perfused during diastole. Hence the excessive vulnerability of the subendocardium as compared to the epicardial surface of the muscle to ischemia. This is an exemplary electrocardiogram of a patient who had normal EKG with the normal ST segments in blue, which turned to be positive and indicative of ischemia, subendocardial ischemia, manifested by ST depression, red arrow. This is a typical picture of patient with subendocardial ischemia due to a mismatch between increased demand and limited blood flow. The implications of this physiology are quite significant at the clinical level. Due to transmural nature of coronary perfusion from epi to endo, and due to the compressive characteristics of muscle contraction, the subendocardium is the most sensitive to altered perfusion regardless of the cause. So the subendocardium will always show the first sign of ischemia. As a matter of fact, in clinical cardiology, there is only one condition that causes transmural ischemia, and that is a total vessel occlusion. Therefore, if you see a patient with chest pain and they have EKG evidence of transmural ischemia, then this patient has total vessel occlusion, and this becomes a medical emergency, and these patients are taken immediately for intervention in order to restore coronary blood flow. Whereas there are a quite wide range of conditions which result in a mismatch of ischemia, mismatch between demand and supply, and these will cause subendocardial ischemia and not transmural ischemia. Please note there is nothing called subepicardial ischemia. It's always either subendocardial or transmural, but you cannot have a situation where there is ischemia of the epicardial vessel, of the epicardial myocardium, because it is the least sensitive to myocardial ischemia. This is a typical translation in real life of what happens during sustained myocardial ischemia, such as acute myocardial infarction or severe interruption of coronary blood flow. At the arrow, you see the area of infarction or tissue necrosis proceeds and progresses from the innermost towards the subepicardial layer of the heart, depending on the duration and severity of myocardial ischemia. In sharp contrast to the EKG, which shows ST elevation, which is a patient who has total vessel occlusion and transmural myocardial ischemia, as shown by ST segment elevation. This is the kind of situation where patient is rushed to a cath lab in order to open the vessel, causing transmural through and through myocardial ischemia due to total vessel thrombosis. Let us now recap on the highlights of the coronary circulation. The coronary circulation is such that blood flow must meet demands at all times. It's auto-regulated. The blood flow is directly proportional to the perfusing pressure. In this case, it is the diastolic and not the systolic pressure. It's also directly proportional to the time available for perfusion. The faster the heart rate, the shorter is the time available for perfusion. Coronary blood flow is inversely related to resistance. And the resistance, you must keep in mind, is contributed to primarily by the microvascular system and to a very minor degree by the epicardial vessels under normal situations. Because blood flow takes place in diastole, the diastolic myocardial tissue pressure is another source of resistance to flow. The higher the LV and diastolic pressure, the more is resistance and the less is the flow. And this is of great importance and relevance in patients who have elevated end-diastolic pressure, such as heart failure, or in patients during ischemia, because ischemia impairs relaxation, as we said, al-khannaq al-sadri, and therefore during ischemia there is a vicious cycle of decreased perfusion, rising diastolic pressure, and a narrower degree of tissue perfusion. When we talk about coronary disease, you must remember the role played by the plaques, the stenosis, the narrowing in the epicardial vessel, which impede blood flow to a variable degree. Exercise has an important effect on flow, and we'll come to this in a second. Moving forward, and in order to expand on the effects of coronary plaques on flow dynamics, we have to recall the Bernoulli equation, which states that pressure drop across a stenosis in a vessel is inversely related to the minimal stenosis cross-sectional area. The pressure loss across a stenosis, the pressure drop, called delta P, is also flow dependent. The stenosis resistance increases during vasodilatation. So if you look at P1, which is the pressure before a stenosis, and P2, which is the pressure distal to the stenosis, the distal pressure will drop as you increase flow. And this is of great importance, whether it's an exercise or during pharmacologic interventions. And it has a great bearing in clinical cardiology, and we'll come to this in a second. Again, looking at the Bernoulli equation, it's really about pressure loss across a stenosis as a function of stenosis severity, stenosis length, or increase in flow across it. And you see that pressure distal to a narrowing will decrease as flow increases across the stenosis due to friction and turbulence. This effect is increased if you increase stenosis and or you increase the flow. And this is of great clinical significance, as well as of great relevance to doing evaluation in a patient with unclear severity of stenosis. Here is an example of actual physiology in the cath lab, a real patient with a borderline significance lesion in the left anterior descending. In red, you see the pressure proximal, P1. In green, you see the pressure distal to the obstruction. And you see that when we give vasodilatation, the green pressure shifts downward, indicating a lower pressure as we increase flow across the stenosis. This is called FFR, fractional flow reserve, and this has become a game changer in clinical cardiology. We do it at all times in order to evaluate lesions and make decisions. And this test in the cath lab has become one of the most important and most impactful decision makers in modern cardiology. At this stage, we must recall the importance and significance of the microcirculation, a very large network of vessels, which has a dominant function in regulating coronary perfusion. The loss of this function and the inability of these microvessels to vasodilate as needed can cause a significant syndrome of myocardial ischemia. At this point, then, we must conclude this segment by emphasizing that in ischemic heart disease, there are not two, but three important elements relevant to ischemic heart disease. One is the presence of the plaque in the lumen, and which exerts its effect through flow limitation depending on the degree of stenosis. And the second is the biology of the plaque, the chemical composition, the inflammatory potential, and therefore the tendency to cause thrombotic consequences. And the third element is of great importance, which is the macrovascular integrity or dysfunction. And the macrovessels now are responsible for a significant clinical syndrome of myocardial ischemia in the absence of epicardial vessel disease, and also has relevance in the wide spectrum of clinical conditions in clinical medicine. And now we come to what matters most in ischemic heart disease, myocardial ischemia. Myocardial ischemia is a break in the balance of demand and supply, which results from either an increase in demand versus fixed and limited coronary flow due to epicardial vessel narrowing and or microcirculatory failure to increase flow, versus a primary and more dangerous situation, a primary reduction in flow, as happens during coronary thrombosis or coronary spasm induced by a variety of causes. Let us now review and try to understand more deeply the consequences and the manifestations of ischemia, which vary from benign and mild chest pain to severe and profound ischemia and a fatal outcome. The consequences of ischemia are determined in accordance to the context of the mechanisms involved in the precipitation of ischemia, the severity of the ischemia, and its duration. Starting with diastolic abnormality, which result from the inability to sequester calcium from the interacting actin and myosin fibers, and therefore the muscle fibers will be in a state of semi-contraction, and this results in very stiff myocardium and decreased compliance in diastole. And here the patients feel short of breath, as well as khannaq, they feel suffocating. Second is chest pain, we call it angina pectoris, which is a retrosternal pain with radiation to the neck, to the elbow, to the shoulder, or to the wrist. These are very characteristic for patients during myocardial ischemia. However, unfortunately, some patients can have ischemia without any clinical manifestations. Systolic abnormality also can result from ischemia depending on the severity. Electrical or ventricular instability are extremely dangerous and are responsible for sudden death even in the very early seconds of severe and profound myocardial ischemia, as occurs in the early stages and phases of acute ST elevation myocardial ischemia. And if the ischemia is lasting beyond several minutes, then cell death and myocardial necrosis and infarction can ensue. And these will be discussed in the pathology lectures. Again, ischemia underscores the link to symptoms, morbidity, and mortality in ischemic heart disease. As I said, consequences of ischemia depend on the mechanisms and the context. We make a big differentiation between low flow versus zero flow scenarios, as well as the suddenness of flow interruption. In order to understand the differences among the ischemic mechanisms and consequences, let's briefly again review what we have learned so far on myocardial metabolism. Normal perfusion involves aerobic metabolism of free fatty acid to ATP. During mild or low flow ischemia, as occurs during a mismatch, there is a shift to anaerobic glucose metabolism to lactate. This is a mildly ischemic acidotic state. However, the cells can maintain their viability and patients can usually survive this without a problem. During zero flow or no washout, such as exists in patients with ST elevation or transmural ischemia, that is total vessel occlusion, there is profound ischemia characterized by severe intracellular acidosis, inhibited and interrupted metabolism. There is no more active metabolism. There are important and potentially dangerous electrophysiologic instability, such as ventricular fibrillation, ventricular tachycardia, and sudden death. And if the ischemia persists, this leads to time-dependent cell death and myocardial infarction. This slide highlights fundamental facts about coronary physiology. I ask you to review carefully every single statement and identify any concept which you think needs further clarification. At this time, I would like to thank you for taking the time to learn, to study, to think about this extremely impactful material. I look forward to have our interactive session in order to review and answer all your questions.